Okay, well, good morning, everyone, and thank you, Colleen. I'm going to get started, and as I do, I always like to emphasize that for some of you, this information is really just a repeat and a review, and I think there are many times, particularly during the pandemic, that sometimes we do need to have these refreshers or these reminders of some of the things that we do know, because when we're under stress, they may not be in practice. So I'm just going to outline for you a few important things that we do know about increasing our cultural competency in working with various populations and communities. As I begin, I first like using from the National Center for Cultural Competency at Georgetown University, their definition of culture. And I am going to read this. I make a habit of not reading from each of my slides, and you will be receiving a copy of the slides also. But I think there's some important components here. When we talk about culture, we're talking about an integrated pattern of human behavior that includes thoughts, communications, languages, practices, beliefs, values, customs, courtesies, rituals, and manner of interacting and roles, relationships and expected behavior of a racial, ethnic, religious, or social group, and the ability to transmit the above to succeeding generations. So as you're reading this, you're recognizing that while we think of culture and we think of race and ethnicity and other diverse communities that we have, we want to be mindful that a lot of what culture does is it influences decisions and it influences interaction, and it also might create what is considered expected behavior. And that expected behavior can be on both parts. It could be from the person and the culture they come from, but it could also be based on their own experience in dealing with individuals of a culture different than theirs and how they may interact with them. So culture gives us meaning. It's basically this filter which we process our life experiences, but it also influences our values, our actions, and our expectations, and people's perception and expectations of others. Now, as public health professionals, we're pretty familiar with the social determinants of health, and we know that these are certain characteristics that help people or might hinder people to receiving adequate health information or services, or even influencing decisions about health. Now, there are many core determinants of health that we know can be part of the intersectionality. I'm going to define that word in a few minutes if you're not familiar with it. But there's many different core determinations of health that influence us in our health-seeking behavior or health-seeking practices, and also how we ourselves may deliver healthcare services. Now, going back to expanding or raising our own cultural awareness, we look at it in a staged model. Okay, now this is just one model, one example of, there are times that, and this is, I'm speaking in general from many of us, we might have experienced cultural blindness. And that's a term that's a little hot-baited when we talk about I'm blind to color. That's not what cultural blindness is. It's really this, it's an unconsciously unaware. It's basically when we talk about raising our cultural awareness, when we begin in cultural blindness, it's like, I'm not really even seeing it, so I'm not really seeing anything that I need to change. Then we become more consciously aware, and we increase our sensitivity. So we're like, oh, because there might be something that is interfering with how services are received or delivered. And then we become consciously aware. And that's when we have our competency that we're able to make adaptations and be flexible. Moving beyond that is when we reach a level of proficiency. Now, there are many individuals who can challenge the idea of proficiency, but if we look at it from just being unconsciously aware, which means that it's your typical manner of interaction with others and not something that you are continually reminding yourself that you need to do, that doesn't mean that we're going to be proficient in every cultural group or communities that we come in contact with. That would really be impossible. But we can become more proficient in that we know and we practice an awareness that as we're interacting with them, we are also aware of how the cultural interactions may play out between how our culture is perceived, whatever culture you're from, how that is perceived by the person you're working with, and also what the person you're working with, their culture has basically taught them. So again, going back to how we can develop our competency, well, there's the knowledge acquisition. So we learn about different cultures. We learn a lot more about the needs of the general public. That's part of being a public health professional. But competency comes when we also reflect on our self-awareness and our own attitudes. What am I bringing to the interaction? I become aware of my own perception, my own interaction, and that helps me to develop my skill set. So skill development, knowledge acquisition, but also becoming aware of my own self-awareness. Knowing how I may be perceived by others is part of my self-awareness. For those of you that know me, you know that I am excuse me, I'm a public health social worker. So I have a credential in social work and I work in public health. Prior to my position with the university, I've been with the university now for 20 years, I worked in psychiatric care. I am a very big man. People know that when they see me. It's not something I hide, it's not something, but I do know in certain environments, particularly when I was interacting and working with individuals who have severe and persistent mental illness, just my size can be very intimidating to them. So my awareness is that I need to keep myself in a position physically distanced, physically lower, maintaining eye contact, not appearing, but breaking eye contact periodically. So I'm not imposing or intimidating to the other individual who is having their own thoughts of, why is this big guy coming towards me? I mean, they know I'm a social worker, but they also know that I'm a big person. And is he here? You know, if there's going to be any physical aggression, it's to my disadvantage to appear too imposing. Okay, so that's just part of my own self-awareness. That is not saying that I stand back and stand away, but I do know I have to be aware that just my size in of itself can be challenging to others. Many years later, I became aware that even my race and my ethnicity can be challenged to others. My age can be challenged. That's all part of self-awareness, depending on the individuals I'm interacting with. So each of us need to be aware and have our own self-awareness of how others might perceive us. That's also a good question to ask a friend or a colleague. How do I come across to you is one way that we can raise our self-awareness, but we also take ownership of the attitudes that we have. As I was saying, for me, how I speak to someone, the tone that I use, particularly in the whatever function I'm doing, can also make a difference. So we have certain blocks that interfere with our cross-cultural relationships. Now, some of these are a little bit more obvious, and some of these not so much so. The important thing is that we recognize that there are components of them in many of the interactions that we have. So we need to be, again, that's part of our mindfulness, that's part of our self-awareness to recognize what some of these blocks may be and which are the ones that may interfere with you in your interaction with others. When I talk about interaction, again, we're talking about individuals who may be of a different population than the population that you represent. And again, the population that you represent may not be the population as other people see you. So we all have aspects of our identity. This is just a range. These are some of what we refer to as the core aspects of our identity. Now, each individual, though, connects to these aspects at a different level. For some, our age may be most significant. For others, our religion, our socioeconomic status, our sexual orientation, our race, our family of origin, excuse me, may be more significant or have a greater influence in our personal lives. That doesn't mean that for other individuals, they also rank these in the same order. This is not in a particular order, but just showing the diversity of core aspects of identity and recognizing that individuals will have a different approach to each of these aspects of their identity. If we were to look at it in a different model, here you see the range of diversities. and what may influence someone in their behavior or their health-seeking practices. Now, these are also considered secondary characteristics, and some are also primary characteristics. So if you look at our primary characteristics, the six in the middle, we have age, physical abilities and qualities, ethnicity, gender, race, and sexual orientation. The reason why these are considered primary is these are really not changeable. Now, yes, your age will change, but you cannot change your age. You cannot, I was just gonna say you cannot change your gender. Yes, you can change your gender, okay? And I'll talk about that in a minute. But when someone sees you, that's primarily what they're seeing. They're seeing your gender, and it's based on how they believe you're expressing your gender. So that's primary to you as far as what your gender is, which is how you identify, but that may not be how other people see you. I know that was kind of a short answer, but the point is I'm going to get a little more detail on that. But as far as our race, our ethnicity, our physical abilities, life will make changes, but those things are our primary dimensions of our diversity. The external, the peripheral ones are things that are situations in our lives that also have a little bit more flexibility, meaning that they might be more fluid. The other thing when we talk about diversity is there are some, and many times when we talk about culture, it is often compared to an iceberg. We know that an iceberg, what we see on the top of the surface is minimal compared to what is under the surface. So when we talk about the culture and relationship to an iceberg, what we are seeing is observable behaviors that are at the top of the surface. The core of those behaviors are below the surface, and we may not always have understanding about those issues that are below the surface, where they originate, where they come from. So the other component that is important that we recognize is referred to as intersectionality. Now, this term may be new to some, but maybe others will be familiar with it. Dr. Kimberly Crenshaw originated the concept and the model of intersectionality. And what Dr. Crenshaw identified is that there's overlapping intersection, social identities, and also related systems of oppression, domination, and or discrimination that come into play in each individual, that basically in our own lives, but also in the lives of others. So we need to be mindful that in our interaction, this is also about that self-awareness that we have. We could look at someone and based only on our physical observation, believe that we know quite a bit about them, and that could be very, very inaccurate. We don't know what's below the surface, and we also don't know, out of the many different characteristics which are more primary to the individual, what's more important to them, which are the ones that others judge them by, because that is what might be more obvious in certain situations. So again, I want to go back to just kind of defining cultural awareness and competency. The important thing is that we become responsive and respectful to the health beliefs, practices, the cultural and linguistic needs of diverse people and groups. And then we want to actively address diversity in the delivery of our services. By doing so, we're going to actually help to reduce, the goal is to reduce health disparities in access and outcomes. So there's different ways, and the focus of cultural competency can be, as I mentioned, the provider's perception, but there's also how we systematically gather information. And we in our state are continually challenging because we recognize the information that we gather has limitations to it. We become aware of this when our census was created. The census would often categorize individuals. And if we go back to the previous century, people were categorized as either white or black. And then we started recognizing, well, what about Hispanic and what about Asian? But even when we use each of those terms, they can be very, very limited. But of course, if we say only Black and white, then we're looking race as if it's a binary system. Binary meaning one of two choices. You're either Black or white. Same thing with either being straight or gay or man or woman. But we don't live in a binary. While we have binary systems in place, we need to recognize that binary systems and binary approaches does not meet the needs when we talk about our gathering of information. That's why we need to be a little bit more expansive. And that's what we are currently doing in our state and other states. Also working on communication, client education, literacy, family dynamics, and health belief. Talking about health beliefs, Colleen, I'm going to introduce the poll right now. So I'll give you a minute to set that up. What I'm going to ask the participants to do, we have 2 poll questions. I'm just going to ask you to reflect on what you recall growing up when you're answering these questions. There's no right or wrong way to do it. It's just, we just want to show, and it's going to be anonymous. We just want to show in general some of the health beliefs that we may have been raised with. Colleen, are you ready? Colleen's muted right now. Maybe I need to stop sharing the screen. Okay, let me give Colleen a fair warning. Let me go back. Colleen, just unmute yourself and let me know when you're ready to do the poll.
Phil, I'm sorry. Yes, I can do that.
Okay.
I apologize. My sound was down.
I know.
Okay, I'm ready when you are. First poll?
I'm ready. Yeah.
Okay. Okay, are you seeing the poll, Phil?
I see the poll, yes.
Great. Okay, folks, you can go ahead and complete.
Now remember, this is what you recall growing up. How did your family receive the majority of information about health and wellness? And you can check all that apply. Colleen, are responses coming in?
They are coming in.
Okay,
Yep.
good.
We are about halfway through. Responses are coming in pretty quickly.
Give everyone time to read the response, what the options
We have
are.
about 30 more to come in, Phil. And they're still coming in. It's definitely slowing down. I think we have some folks also who had called in, so they may not be able to answer the poll.
Okay.
So we can stop there. We're at just about 120.
Okay, very good.
Would you like those results shared, Phil?
Yes, please. Please share the results. Okay, now, I just want you to think about, the question was asking about your experience growing up. Filter it through your experience now as a healthcare professional, be it in public health or be in direct care services, okay? Because the information you receive now is very different than the information many of us received growing up. Neither is right or wrong. It's just the information we received when we were younger kind of created a core belief system around healthcare. As we get older or as we acquire our education, some of those belief systems can also be changed. Anything that's been learned, if it's learned incorrectly, can be unlearned, but not everything we learned is necessarily incorrect. It may have been correct for you at that time, or it could be more correct for you in your own culture and background. So let's just take a look and see that, yes, we do have television, news, and radios, magazines, etc. But then we have family doctors are leading, but then look at whether or not people are getting it from a school nurse, from the church, from a hospital, from a clinic. Scroll down a little bit, Colleen. We can't see the last of the.
Down below, you have first aid,
yes,
other sources, and not sure. And those are.
Let me see what those responses are. Were there? Oh, there we go. I was able to move it too. Okay.
Okay.
So Other sources, so there's even others that were not included in the poll. I'll just make my own observation. Growing up, I lived in a very small shore town in New Jersey, born and raised, very proud of that. Okay, I grew up on the Bay Shore. So we had a volunteer first aid squad. There was a first aid building. There was a siren that went off when the first aid needed to be called in to an alarm or to a call, but it wasn't like a place we can walk into. It wasn't open to the public. And the same thing with our fire station. It was pretty much a volunteer fire. It wasn't until I got older that I heard from other individuals who said, we went to our neighborhood first aid or firehouse. We walked in and we talked to the people that were working there, and they gave us information. They gave us services. We might have needed something, even if it was just a Band-Aid. We see, even people had trouble with their bicycle to have their brakes looked at. They might walk into the firehouse and ask one of the fire personnel to, what's wrong with my brakes on my bicycle? I never thought of that because it wasn't in my neighborhood. I might go to the local gas station and ask the gentleman who ran the gas station if he could take, and of course he didn't like taking a look at bikes, but I mean, it wasn't necessarily his job, but as part of our community, he understood that bike safety was important. And if he had time, he would check out a bike or tell us what we need to do and tell us what we need to do to correct the situation. So the important point here is that we see there's even among a group of individuals that we have a very common similarity as far as being professionals in healthcare and public health. We have a range of diversity about how we received our information growing up as far as healthcare. So, Colleen, let's do the next poll. And we'll give you a few minutes to answer. Now, this question is different as far as where or who provided the majority of your healthcare growing up. And again, please check all that apply.
We are about halfway, Phil.
Okay.
We'll give it another.
I think the first time
seconds.
took a little time to adjust to what am I doing here? How does this work? A Zoom poll? It always confuses me in the beginning.
And we are just about 10 away from where we were before.
Okay.
So I think you can probably start, Phil. Thank
Sure.
you.
Go ahead. You want to just show us the results? Okay, so again, okay, we see a range of diversity growing up where we received our healthcare. And here we see why many people did have a family doctor or pediatrician. Not 100%, 89% are familiar with going to a family doctor or pediatrician, but for others, it might have came from another source. The health clinics, the school nurse played a very important role does play a very important role in many communities and still today. But for some of us growing up, that's where we got most of our health information. But then also we have 38% got their health information from an adult member, which is good. I mean, information is being passed on, but we don't always know what the source of that information was for that adult member who passed it on to us. And then others might have relied on a neighbor. That's one of the boxes that I check off because there was a woman in our neighborhood who was a nurse. So many times that there was a health question, my mother might have a conversation with her, not imposingly, not every day, but occasionally say, can you tell me a little bit about this? Or what do you think, is this something that we should bring to the doctor? And that was part of her interaction as just being a friendly neighbor. There were other times that I remember just a neighbor had a little bit more experience about a certain ailment, and she would give my mother different advice. I remember one time as a child came down with a case of poison ivy. At that time, I wasn't brought to the doctor. It wasn't considered relevant with poison ivy, unless of course maybe it got into your eye or something like that. But in my family, growing up, we played in the woods. We always came down with poison ivy. So we had different treatments for it. And then I remember a neighbor one time, she recommended, my mother would always put calamine lotion on, and she recommended this ivy dry. I don't really know what it is. It's not really important about it. But the point is, like, my family never used it. Her family did. She shared it with my family, and my poison ivy went away much quicker than what I was used to using, just using the calamine lotion, which took away the itch. So the important thing is that family members and neighbors can also play an important role in passing on information and resources. And we need to be mindful of that when we're dealing with the public. Okay, Colleen, we're going to close you out, and I'm going to go back to my slides. Okay. Colleen, just confirm you're seeing.
You're good. You're good.
Okay,
Thank you.
as I was mentioning, and this last one of the last focus areas of cultural competency is health beliefs. So we have the health beliefs that we currently possess, but we also have the health beliefs that we were raised with. And as I said, we need to be mindful sometimes of what is the source. I often say to clients, what is the source of your information? Where does that belief come from? And how do you know today that it's accurate for you? Is it still accurate for you? It may have been accurate for you at one time. So it's not challenging the person as far as saying, no, you're wrong, but just asking them, what is the core of that belief? Where does it come from? And do you believe that is still true for you today? We go a little more to advanced. Now, here's where we're going to switch lenses a little bit when we talk about cultural humility. Cultural competency is the acquiring of skills, knowledge, and reflecting on our own attitudes and our self-awareness. When we practice cultural humility, that self-awareness becomes more important, because this is when we recognize that my culture is not the only culture, my beliefs are not the only beliefs, okay? But it also recognizes that I can learn more from the patient when I ask them certain questions that might help me to gather and visualize or connect with them on a different level as far as what their beliefs are, okay? The other thing is that I become aware of if I'm making generalizations, okay? So cultural humility is actually what we refer to in medicine as a patient-centered, patient-first approach. We're talking to the patient, not at the patient. We're talking with them. We're asking them what is important for them. What are the decisions that they need to make? What is the information that they need to have, as opposed to telling them what they need to do, asking them what they are interested in doing, what are they willing to do, what do they need more information on. So we can learn more about a person's culture when we practice cultural humility. We can learn more about their understanding of health-seeking behavior when we practice cultural humility and ask the patient a little bit more about. Now I understand, and again, this part of the presentation may not be specific to the work that you are currently doing, particularly if you're working at a vaccine. Your interaction is going to be rather limited, but that doesn't mean that there won't be times that you can have conflicts with a client or a patient coming in can be conflicted with you based on their experiences coming into a clinic, whatever a clinic may be, or whether it be a mega site or a smaller health department, just how they perceive seeking or acquiring health care or health behaviors. So I just want to go back, to the diversity, because we also want to be able to value and respect the differences of our communities, okay? And also not to make any assumptions about different communities based on what might be a limited exposure. That's when we start stereotyping. We hear something of a particular community and we believe it's true for every member of that community. That can be very, very risky, okay? The important thing is that we do remember is that the choices that individuals make are powerfully affected by culture, what they were taught, what they believe. And again, I go back to what they were taught, but also what they believe, what their current beliefs are. But that is something that we know beliefs can also be adaptable, changeable, or flexible. For some, they're very set. For others, they can be influenced or they can be motivated to change. We talk often about motivational interviewing as one way to increase healthy seeking behaviors. So we not only recognize the diversity between cultures, but also the diversity within the culture. So some individuals can be exposed to many different cultures, and some individuals come from a very multicultural background or experience. We also know that the media, the school, the television, books, etc., and other activities often give us opportunities for many multicultural experiences. Again, I can only talk about my own childhood growing up. When I was in grade school in the 60s, we had very, in my world history class, we would learn a little bit about other cultures, okay? I know as a young adult, when I started to participate in heritage festivals or cultural festivals, which became very popular, I think that I recall, maybe in the 70s, that you would actually spend the day, go to a park or go to a museum or go to a public exhibition, and there'd be a whole range of individuals talking about a particular culture or particular heritage and sharing their ethnicity with others, that I was really much more enlightened. What I learned in grade school at the time, for the generation I was from, was adequate, but there was so much more. And that's where the exposure to multicultural experiences became very significant for me and very important for me. Again, I just want to go back and restate about not to make assumptions because of a cultural belief that it's actually shared between all different members, including linguistics, religious groups. The larger groups may have a common historical or geographical experience, or they may have a common belief, but that doesn't mean that every belief and every practice is going to be the same for every member of that community. Now, this next statement is sometimes challenging for some when we say that race is a socially constructed that people use to associate behaviors and attitudes with physical characteristics. Just let that sink in for a minute. Race is socially constructed, okay? Who we are born, the color of our skin when we are born, our ethnicity, our origin, okay? That's part of our culture. How other people perceive us is what society constructs. So it becomes socially constructed. I'm going to talk about that a little bit more, but I just want to just put that out there first for us to kind of start thinking about when we talk about diversity. Because then we also go back to have some of these challenges, okay, when we talk about race, ethnicity, culture, diversity, and other minority groups, okay? And these are some of the challenges that we have experienced, or can still be currently experienced by many different individuals. The other qualification I wish to make, or just kind of state, is that there is a distinction between inequity and inequality, okay? That these terms are not interchangeable, okay? And there's certain components that are changeable, that when we say are changeable, okay, they're not interchangeable. Inequity refers to unfair or avoidable differences arising from poor governance, corruption, or cultural exclusion, while inequality simply refers to uneven distribution of health or health resources as a result of genetic or other factors or lack of resources. Now, in our country, we have adapted what's referred to as the class standards. I believe you're probably a little bit more familiar with this than some other groups, but they're the national standards for cultural and linguistically appropriate services, CLAS, C-L-A-S, in health and healthcare. What it is there's actually, and we have the link here that you can view this is from the Department of Health and Human Services, HHS, okay? You can get a PDF and it gives you these, this is just one summary, there's several different publications at the website, but there's basically 15 different action steps that are intended to advance health equity and improve quality and help eliminate healthcare disparities. So there are steps that we can take. And remember, as I said before, just like for our clients, they can relearn something that they mislearned. We can also change our approach by recognizing some of the action steps that we can take. If every problem we see looks like if the only tool we have is a hammer, then every problem we see is going to look like a nail. There are other ways and other things we can do. And the class standards are very, very significant in how we can approach working with diverse communities. Now, again, going back, and my race, I'm a Caucasian man, okay? So I am not an expert on racial disparities, okay? But that doesn't mean that I can ignore it as a public health issue, okay? And also that why we are talking about it more in the past 2-3 years, and for some of us going back even much, much longer, okay? But we're also recognizing that there are other communities that are also challenged. There's additional, when we talk about, we can talk about people of color, Black and brown communities, some people refer to them as, okay? But then what is the difference between a person of color who is elderly and also dealing with a disability? What about homelessness and disadvantages that might exist among different groups, okay? And therefore, so we don't want to put everything into the lens of racial disparity, because, and I'm not saying that's not important. What I'm saying is that we need to also recognize that there are also other minority groups that have their own unique set of challenges that may be very similar, but are also very different than the effect of racism. So let's just look at, okay, 4 communities in New Jersey: white, Black, Hispanic, and Asian. These are the percentages that are reported by our state who have been vaccinated. This is as of the 25th, okay? Those that have received 1 dose, so partial, vaccination, okay? The number for white and Asians is much higher than the percentage for Black and Hispanics. For those that are fully vaccinated, okay, here we see that again, the Asian community fully leads with the greater percentage of individuals that are fully vaccinated, percentage-wise, okay. Here is just another breakdown because it gives a comparison, okay, of, and again, social worker, I'm probably not the best person to be going over demographics with you. There are many other people that are much more knowledgeable about research and statistics, but I'm just using this slide to show you a representation of where we see some of the disparities that exist within our vaccination clinics. Now, this comes from another source. This comes from USA Facts, and you can go there and they have almost daily or weekly updates, okay? What we do know, okay, which is to our benefit in our state, that 74% of the state have received at least 1 dose and 66% have been fully vaccinated. So I want to go back and clarify what I mentioned before, which was minority stress. We don't know if there's a reason why some people are not coming back for their 2nd dose. Could it be they experienced stress coming the first time, and that might not be limited to a minority? Could it be a belief that 1 dose is all they need? The important thing we need to recognize is that we do want to get more people fully vaccinated, and we even want additionally people to get the boosters, those that are required or needed. Okay, so when we talk about minority stress, we see high levels of stress faced by members of a stigmatized minority group. So there's many different factors that can cause this, okay? Now this has been documented. This goes back, here we see the first article, 21 years ago, 22 years ago, okay? Our colleagues here, their publication when the American Psychologist was Racism as a Stressor for African Americans. So we recognize that being a member minority is going to have additional stress factors in it. That is a byproduct of the racism. That is a byproduct of how others in society treat you is going to increase your level of stress. Now, when we talk about under-vaccinated, okay, so we know that 61% white Americans make up 61% of the population, but of them, only we have 61% are fully vaccinated. So we're missing 39% of the white population, but then Hispanics, okay, Hispanic Americans make up 17% of the population, but again, only 17% of them are fully vaccinated. That's a wider discrepancy. And then when we talk about African Americans, who make up 12% of the population, only 10% of them, of African Americans, are fully vaccinated. There are other groups also that are also disproportionately represented. We don't have detailed specifics on each of those other minority groups currently. And that goes back to the other, when we talk about, in the previous slide, when we talk about how do we gather information, which is including in our statistics and in our data. Now, I went to another source, okay, which is the Kaiser Family Foundation. It's not affiliated with Kaiser Permanente. Kaiser Permanente is an insurance company. Kaiser Family Foundation is a national think tank on healthcare services, okay? And they did polls, you know, nationally and regionally, asking individuals about their trust of the healthcare system. So the majority, even among unvaccinated adults, the majority do trust their own doctor, their pediatrician, and their health insurance companies, and also their employers. So, but also trust in other sources is somewhat lower among vaccinated adults, okay? Now, here we see about half of unvaccinated adults say they trust the CDC and the FDA and their local health department, but 4 in 10 trust the state government. So here we see another discrepancy, that when it comes from a local source, particularly our local health departments, the community may be more receptive than when it comes from the state level or federal government. And then even fewer, about, this is for those that are unvaccinated, about 4 in 10 trust their state government, but even fewer trust either President Biden or Dr. Fauci, okay? So the trust in government sources of information is essentially low among those who say they will definitely not get the vaccine. Now, the reason why I use the statistics is, so if they're not trusting the government, but we do know they do trust their doctor, their pediatrician, and their healthcare provider and their employer. So how are we getting the information to them? They're dismissing it from the federal government, but they will listen to it when it comes from a more local source, particularly a healthcare provider they're connected to or involved with or receiving services from, including our health or our local health departments. Some people have asked, and just for clarification about religious exemption, yes, religious exemption does exist. However, in other states, religious exemption is used more frequently. In New Jersey, it is not something that is used, so I'm going to say maybe capriciously. There needs to be weight behind a decision to grant religious exemption, okay? And our religious exemption laws, it goes back to the mid-70s, okay? But the exemption may even be suspended by the State Commissioner of Health during an existence of an emergency as determined by the State Commissioner of Health. So even then, our state has the authority to overrule a religious exemption if it is declared an emergency. Going back to the how healthcare professionals then, you are the most trusted individuals for many of the members of our community, okay? So that's an important tool, that's an important asset that you can work with. How are you giving the information? And so it's not a question of what information you're giving them, but it goes back to how are we giving the information? I just want to give a little bit more emphasis of some of the information that Kaiser Foundation identified in their more recent research. So white people account for the largest share, 60% of people who are unvaccinated. Black and Hispanic people remain less likely than their white counterparts to have received a vaccination, leaving them at an increased risk, particularly as the variation spreads. However, the data does show that these disparities are narrowing over time, particularly for the Hispanic community. So some of the efforts and some of the education campaigns and some of the outreach efforts that are being orchestrated are increasing protective factors and decreasing some of these risk factors. I know that I observed, and I'm someone, I worked as a social worker, I worked at our county's vaccine clinic. So I had interaction with the public. I was there as a resource person to help, keep people calm and make sure no one got too anxious. And that was part of my role as a social worker. That's what part of my training, okay? I know that just visually, I didn't see as many individuals, particularly from the Hispanic community, coming into the clinic that I was in. I was in the clinic very early when the clinic first opened, right after I got my vaccinations. But the point is, when I saw on the news media that they started to arranging mobile units to do vaccine into the community, that nurses and doctors and others went into the community, and they went to churches. They went to Black and Hispanic churches and offered vaccines out in the parking lot. Same protocol as far as administering the vaccine, same protocol, same cards, and data was collected as far as confirming who was receiving the vaccine, but they made it more accessible by going where people met, and they established collaboration with members of the faith community. That was a major push that we saw, that we started to see the disparities start to come down. So that's an important consideration. We also, New Jersey started to create specific campaigns that help to educate. I'm just going to show, Colleen's going to set up on the screen for us. Now, this is a toolkit of resources. If you're not familiar with it, or maybe you are, hopefully you have them, but if not, I encourage you to check it out. You're going to see the PDF file there that you can download. But let's just take a look at two samples of how health information tailored to communities of color have been developed and utilized and could actually influence better health-seeking behavior and elimination of disparity. Colleen, are you ready to share?
Sure, Phil, you'll need to stop sharing.
Okay. See how we work well together? These are very brief, just a minute and a half.
Oh.
Can you go full screen?
I can. Okay, I'm going to play. Just confirm you can hear the sound, Phil?
Sound.
I felt a little bit flushed, and then I had some arm soreness that was more intense than what I'm used to from the flu vaccine. It probably is more similar to when you get a tetanus shot. With the second vaccine, so far I've had not that many symptoms. If someone is going to have side effects, it's more likely that it's going to happen after the second shot because we're boosting the immune system. And so that's where you get those side effects.
Okay, thank you. And let's do the next one. Thank you.
The more you see of the world, the more it rewards you.
My mom lives with me.
With
She's
every journey you
91
take, be rewarded with points for stays, airline miles, experiences.
Yeah, you got another video playing in the background.
old,
Okay, Colleen,
and
thank you.
My mom lives with me. She's 9 years old. And I really felt it was important that our entire household was vaccinated. I know many people who are hesitant. I totally understand. What I've told them is this is a very, very personal choice. And for me, it was just the most logical choice for me, for my family, for keeping myself safe and keeping my family safe.
Okay,
Okay,
share.
I'm going to go back to screen share. Okay. Now, if we're in a live presentation, we could have a little bit more of a conversation about this, but I just want to point out that these messages were not only delivered to speak to communities of color, but the representation. We have a very, knowledgeable doctor, a professor at Rutgers University. She works in the Division of Infectious Disease, but she's also a woman of color who is a physician, and she spoke about her own, what she experienced going through being vaccinated. that carried greater weight to when a minority person is viewing this, when a person of color is viewing that and seeing someone who represents their community. The same for our Susan Pope, who is the school teacher, okay, who talked about not only her own concern, her own anxiety, but her concern for her mother. So the family connection was relevant. And also she understood and she talked about, yes, some people are going to be anxious about that, but that's okay. She believes it's a choice, which is an important issue for many people because we have so much opposition. As soon as someone's told not to do something, for some individuals, their first choice is don't tell me what to do. So she acknowledged in her message that I know it's a choice and it's a choice that I made because it's important to me. Those are very good culturally appropriate messages to come across. Others can relate to them also, but particularly we know from experience that when you're in a minority position, if you're a person of minority experience, when you see representation of your community, you're going to notice it, you're going to take it to a different level. Okay, let me continue on here. So again, also in these messages, de-emphasizing race and how we provide health care and classify our patients and assign casualty, while we're increasing our emphasis on race and how structural and institutional racism leads to health inequality, okay? Institutional racism, to give you an example, would be when we have only white male doctors speaking about the vaccine, when we have all our educational pamphlets and all our materials that we distributed are only showing Caucasians, or only showing men, or only showing middle-aged men or older men, okay? So there are ways, again, it goes back to how we can improve their outreach messages, and I think our state recognizes that, and we recognize some of the challenges. These are, we're being forced as an industry, as a healthcare professions, whatever it be, that, as much as we learned about pandemic, you really don't know what's going to happen and how it's going to unfold. You're actually living through the experiencing, or as CDC likes to say, you're building the plane in flight. So we're going each step of the way saying, okay, so what can we do better? How can we improve? How can we reduce some of these disparities? Another component I want to bring up, because I spent a lot of time talking about racial and ethnic minorities. I didn't spend as much time, I haven't really covered religious minorities, but I know that there can also be challenges for them. But I do want to talk about gender identity, because this we've found, and we have heard reports that this can be confusing sometimes within certain vaccine clinics. So the whole phenomenon of gender identity and gender expression is not something new, but it's something that has gotten a lot more media attention. Okay, there have always been transgender individuals. Transgender is an umbrella term for a variety of individuals who express their gender differently than the gender they were assigned at birth. Now I have, and I do teach, some of you may know, I have a full, half-day presentation, and even there's 20 hours of educational information I have on working with LGBTQ communities. We don't have time for that right now. So I'm just going to give you a brief version about some of the considerations that we may need to consider when working with the LGBT communities, particularly those who are part of the trans identity community. So as I said, yes, in the 6-hour course or the 2-hour, 4-hour course, I can go into much more detail about the range of diversity when we talk about minorities who are identified by sexual orientation, gender identity, or expression. We use that acronym LGBTQ, and sometimes we use the acronym SOGI. Both can be correct. Probably the general public uses LGBTQ, and they may use the I. And then in our materials, our print materials or our research, sometimes it's just referred to as sexual orientation, gender identity, or expression, or just referred to as sexual minorities. So there is a lot of information you can receive. I'm just giving you a very, very condensed version right now of some information that's important for you, particularly those of you that are working at the vaccine clinics. One of the things, our state is ahead of the curve in many different ways, okay, because of, we now in April of this year, okay, the New Jersey Motor Vehicle Commission announced the addition of X as a gender option, often a driver's license was listed as either male or female. How was that determined? It was not determined by the gender that you believe. It was determined by the gender that was listed on your birth certificate or whatever your documentation was. Okay. In New Jersey, a person can request to either have their gender identified as being unspecific, which is gender X, or will be also existing as male or female. And it can be done, okay, this is just the gender marker. It's part of a self-attest. You can request this. There's a form to fill out and you can request this. This is not the same as a legal name change, okay? But you can request to have your gender marker to be changed if you use X and or if you, it's just another option for some individuals. Now, going back in 2020, individuals were allowed to use the male or female gender designation, and they can request to have that changed. And again, this is not the change. This is to have a name change is a legal process, and to have your name changed on your documentation takes a little bit more. But as far as within your driver's license in the state of New Jersey, you can have your gender designation. Gender designations are also referred to as gender markers. So your gender marker can be different as you believe it is than how other people may see you. Some people may question your gender, and there are some individuals who present themselves in life questionable, meaning that they don't question their gender identity. They don't believe in presenting themselves as either in a binary system, exclusively male or exclusively female. They identify as being gender non-conforming or non-binary. That's why the designation of gender X becomes significant to them. A person who is non-binary or gender non-conforming does not want to be pushed into a binary box to say either they are male or female when they don't see themselves as exclusively male or female. So it's important to recognize that some individuals' documentation, their gender markers on their driver's license can be different than as you perceive them when you're seeing them or interacting with them face to face. And I'm going to talk a little bit more about that, okay? But I also want to highlight how COVID has impacted the LGBT community. So LGBT community in general has certain health risks that they're at much greater level for. Often it's attributed to the minority stress status. So there's LGBTQ minority stress. How other people treat them, how other people perceive them can also increase their stress factors, which can affect their health-seeking behavior or their health and wellness, okay? But statistically, okay, we know that there are a greater percentage of LGBT individuals who might experience poverty or lack of adequate medical care, paid medical leave, or basic necessities during the pandemic. There's a greater percentage of individuals who may work in their source of income may come from places that do not offer adequate coverage or adequate health insurance or health benefits, or they may be in a relationship where their partner is not covered or other family members are not covered. There's also, just to give you some, we look at how the effect of coexisting conditions as far as COVID, 37% of LGBT adults smoke every day compared to 20% of non-LGBT. So we know, again, greater health risk with smokers are developing COVID. We've talked about that. We know that it's been studied and examined, but we also know that greater percentage of LGBT individuals are smoker. Another statistics that I've learned from the work that I do is that many non-LGBT individuals decrease their tobacco consumption the older they get, and we don't see that drop off with many LGBT individuals. So again, that's where there's a greater discrepancy. We also statistically identified that, and this has come from the National LGBT Cancer let me clarify that. But anyway, they identified that 21% of LGBTQ adults have asthma compared to about 14% of the non-LGBT persons. So again, we're talking about how there's a greater impact, but going back to the things I started to say also, there are also economic disparities and barriers, And statistically, and then I'm not saying that all, I mean, there are many, many LGBT individuals who, again, live very healthy lives, healthy lifestyles, make healthy choices, have employment with full benefits and everything else, but there's a greater percentage that are also more drastically affected by economic insecurities, okay, which is making it more of a challenge for them because of these economic disparities that exist. So as I started to mention, I did get a little bit ahead of myself. So just looking at industries that are highly affected. So again, we know it goes across the board that our frontline workers, our first receivers, our service individuals, those even, you know, we're talking about people working in grocery stores, cashiers, service industries were all greatly impacted because they had to interact with the public. They were at greater risk of exposure. But statistically, we look at a greater percentage of LGBT individuals who also work in those industries. So about 5 million individuals work in these industries that have a heavier impact of COVID-19. And in these 5 industries, by comparison, they only make up about 22% of the industries where people are non-LGBT individuals. So for whatever reason, many LGBT individuals find themselves working in certain positions in certain industries that could also affect their risk of exposure and or adequate protection against, I'm going to say HIV, I'm going back, sorry, against COVID-19. So just kind of, that was just giving me a little snapshot of some of the minority stress. But I just want to go back to, because of, there is confusion about the gender markers when someone comes in, okay? Now, so someone may present themselves or may express themselves in gender, and some individuals might have transitioned from one gender to the other, the gender they were assigned at birth, the gender they see themselves as, that's their gender identity, but then also the gender they express. Others may express themselves in very fluid, more gender fluid, a non-binary. The important thing is that if you're unsure, it's okay to ask, but what you want to ask is ask respectfully. You can ask the person what pronouns they use. Some use he, some use she, he, him, her, some use they or their, and they can all be correct and appropriate for the individual, okay? Now, if there is a discrepancy, of course, you would do this confidentially. You would do this, I know, like say in a larger vaccine clinic, there's a limited amount of privacy, but you're still, someone is either signing and checking and giving their information. You don't, if you observe a discrepancy, remember, that's your issue, it's not theirs, okay? They've been living the life, they've been expressing their gender as they see fit, as they truly identify themselves. So the challenge for them is how other people may interact with them. If you ask someone their birth name, that can be very, very traumatizing. What name I was giving at birth is not significant. This is the name that I use. However, because we're talking about medical records, we can ask someone, is there a name that's included or part of your medical records? Because if we are documenting you receiving the vaccine, and for consistency, whatever name your medical records are kept in is the name that we would like to use. So it's not the same as asking for a birth name, it's what names. Now, some people may have adapted their medical records into their, whatever their new, if they've gone through a legal name change. Some individuals may choose to shorten their name. Patricia and Patrick can both go by Pat and use that in their medical records. They don't have to give a full first name. The important thing is that we just learn in our terminology and how we interact to ask more respectfully. So asking someone, what might there be a different name that's in part of your medical records? And not to do it, but also you're kind of just letting the patient also lead with you. Now, if you're unsure, just use gender neutral pronouns. Gender neutral pronouns can also be used when you're talking about a family or a couple. You know, instead of saying, is this your husband or wife? Is this your partner? Is this your significant other? The person that you're with, what is your relationship with them? If that's someone that if that becomes part of relevant of the interaction that you're having. The important thing is that if you do slip, just apologize. Short and simple, say, I'm sorry, I didn't mean that. I'll thank you for correcting me. But the more sincere you are, the more the person is going to appreciate it, as opposed to being challenging, coming back saying, well, this is what you gave me, this is what I'm seeing, this is what I'm confused, and then somebody starts yelling for somebody else to come over. That is not how you handle the situation. I'm sorry, I can't deal with this, somebody else is going to have to take care of you, would be very, very disrespectful. And I know the majority of you are probably much more courteous, but it's sometimes when we're stressed, but remember, there's the minority stress that that person is also feeling. So they might approach you being a little defensive. And that's where it kind of goes back to, you know, Walt Disney World does their training on client satisfaction. You know, a smile can do wonders. I'm sorry, I'm just a little confused here. Can you help me to see? First off, let me begin by asking you which pronoun should I use with you? What name would you like me to refer you as? Okay. And now I just need to ask for clarification. Is there a name that's listed in your medical records that could be different? If so, can you provide that to me? Okay, so, you know, I'm just giving you some highlights about some of the diversity that we see. I want to start wrapping this up, okay, because language is important. Our interaction is important, how we deal with diversity, how we increase our not only our competency around culture, but also to recognize that we need to practice greater cultural humility becomes significant, okay? So what we have learned from other groups is sometimes just how we perceive them or how we list them or talk about them can also greatly influence our interaction. So I've been challenged by myself by sometimes recognizing that we used to, many times we talked about underserved populations or the hard to reach populations, the uninsured. We can talk about people who are underserved by COVID vaccinations. We can talk about people who are underserved in seeking shelter, in seeking financial assistance, or in, you know, people who are underserved by behavioral or mental health issues, people who are medically underserved, people who are uninsured, who are underinsured, who do not have health insurance, because of, it's important, again, it's a little bit more respectful that we're not just lumping everyone together. And again, when we talk about underserved, it relates to limited access to services that are accessible, acceptable, and affordable, including healthcare. So the question is, if they are underserved, well, then why is that? If these are services that are accessible and acceptable and affordable. So do not use underserved when you really mean disproportionately affected. There is a distinction in that language and that terminology. And as you present it to others or talking about others, and again, I always go back to it's better to talk with than talk at someone. Okay, our immigration status. And again, I know that, you know, we have gone through a lot in the past couple of years. Well, for some individuals, many generationals, it's a national, there's generational, historical generation of inequalities that exist. However, the terms that we have often used could actually be considered very offensive when we start saying illegals, illegal immigrants, illegal migrants, foreigners, the foreign born. So we can start improving by referring to individuals as people with undocumented status, mixed status households, immigrant, migrant, asylum seeker, refugee or refugee populations, or non-US born persons or foreign born persons, okay? Different ways, because we also know that many individuals, there was a lot of projection of hostility projected on the Asian communities when our former president referred to it as the Chinese flu or the Asian flu, very offensive. And at the same time, it created an atmosphere of, and we saw hate crimes increased among the Asian community. So how we talk about individuals and talk with individuals also has an impact. So I'm just going to summarize now and kind of bring this to a closure. And feel free to, there might be some Q&As. Colleen's going to monitor that for me and see if we'll be able to answer a few of them. You know, one of the greatest sources that I go to, there's many different sources we talk about when we talk about privilege, but I like the teaching of Peggy McIntosh, who was basically a school teacher who started to recognize how students were treated differently. And she created the experiment. She did the original experiment, which was brown-eyed and black-eyed, brown-eyed and blue-eyed students. She was on the Oprah show. We talked about this. It got a lot of media attention many years ago when she first started doing this. And basically, she created an atmosphere. It was for demonstration purposes of individuals with a certain eye color being less than individuals with the other eye color, okay? She also talked about privilege, and privilege in a very basic definition, okay, is an invisible package of unearned assets. Nothing that when you talk about, there are certain privileges, yes, there are certain privileges we have. If you received an education, you have certain privileges. You have greater financial resources, you have certain privileges. However, in the sense of the words as privileges that are unearned, it's just by who you are, okay? That you're giving certain privileges or recognized with certain status, okay? I know as a Caucasian, as a white man, that gives me a certain amount of privilege. I don't deny that. Now, I specialize in working with the LGBT community because I'm also a member of the LGBT communities. I don't have to get into my personal details. I will just share very briefly that I was married to a woman and I never faced any kind of discrimination when I was presenting as heterosexual. The first time I went to find an apartment with my male partner after my divorce, I was told by 3 different rental agencies, we don't want your kind here. Never experienced that before. I went for rentals with my then wife, or even as my fiance, when we were, even before we were married. The questions I often was, oh, how you're such a lovely couple. When's the marriage? When is, you know, like it was all like very, very affirming. 2 men coming in and asking to be on the same lease, and I was met with hostility. I was met with discrimination. That discrimination is illegal. It wasn't illegal back then because I'm of a previous generation. This is for me in the early part of the late 70s, let's say. Okay, so a little bit about privilege. And if privilege, and when we talk about privilege, if it offends you, if it confuses you, just play your own game of check your privilege bingo. See how many of these boxes you can check off. And that tells you how much privilege you have in our society, in our culture, in our community. Okay. I want to give another example because I talked about how the state Department of Health has created these media campaigns and these resources, posters and flyers that will help to educate and represent minority communities as far as increasing access to, not just access to vaccine, but increasing those that currently are unsure about being vaccinated, how we can influence that decision. Well, a number of years ago, many casinos, hotels in Las Vegas were going through remodeling. They wanted to, there was competition. Atlantic City in New Jersey, here we started casino gambling. So there was competition between Las Vegas and Atlantic City. I'm certified as a compulsive gambling counselor. I'm not saying this to promote gambling. I'm just using you as a power of example. So the MGM Grand wanted to change their building front, their facade, okay? Now, they recognized, and it was very common in Las Vegas, that there was a greater percentage of tourists that came in from Asian countries. They were flown in. They were flown in or they got very, very cheap airfare to come to Las Vegas because there was a greater interest in gambling, okay? Not trying to stereotype, just saying it's been statistically proven. Anyway, so the lion symbolically, okay, is very significant in many different Asian cultures. So their designers came in and said, we're going to create this great entrance. It's going to be this giant lion head. And we're going to ask when the shuttles bring people from the airport on these tour groups, they let them off on the street corner, and there's maybe 2 or 3 casinos within that walking distance. Actually, there's probably more than that, but anyway, they wanted something that would bring in, the Asian community into their casino. And like, they're going to see this giant line, and they're going to like walk into the lion's den, and that's going to be so wonderful for them. You think it worked? Not at all. The reason being, the Asian community interpreted that they were being fed to the lions. Not good. Nobody wants to be fed to a lion, regardless of what culture you might be. What they had to do was they had to actually rebuild the facade, and instead they created this golden image, very iconic, in the front entrance of the hotel and the casino. And what many people would do is, as they saw this, they would drawn to it, and they would actually touch it, rub it, touch it. These were all part of a ritual for many of them, that they were connecting with their iconic image of the lion, as opposed to being fed to the lion. So even with great minds, I don't know who the person was, the designer and the architects that came up with the original concept, but if they had talked to the community itself, they would have learned, no, that's not the approach that we want to take coming into a casino, entering into a lion's mouth. Okay, so learning from the community, practicing cultural humility has a greater impact. Going back to clarification though, because we do have the laws against discrimination in our state, and New Jersey has some of the most comprehensive laws against discrimination in our state. The laws against discrimination are governed by our Attorney General, and we have the office of, there's the, first of all, let me just talk about the Attorney General. So our Attorney General, who was recently, he's appointed as the acting Attorney General as of July of 21st of this year, okay? Our previous Attorney General resigned, moved on to a different position. Smooth transition by Governor Murphy, has identified his priorities for his administration are going to be racial justice, gun violence, and policing policy. Okay, so as he says, the COVID-19 pandemic exposed and exacerbated racial disparities that have long plagued our country, and we have a moral obligation to address the problem. This is about more than just having a diverse and inclusive workforce. We must use the authorities and resources of the 17 divisions of our department to promote racial justice statewide. That's a very powerful statement coming from any Attorney General, but particularly I think we can be proud in the state of New Jersey, how they are recognizing the impact of racial inequalities on our communities, particularly for people of color. We have, he talked about the 17 different departments. The major department for any form of discrimination is the New Jersey Division of Civil Rights, okay? They enforce not only the laws against discrimination, but also the New Jersey Family Leave Act, okay? So the mission of the DCR, the Division of Civil Rights, is to protect the people of New Jersey from discrimination and bias-based harassment in employment, housing, and public accommodations. The healthcare industry, our hospitals, our clinics, our health departments are all part of public accommodations, as are, we talk about employment and housing. So all public accommodations, any hospital, unless a hospital or a clinic, a health center receives absolutely no state funding or federal assistance, even if materials are passed on, that is assistance. They cannot deny access to services for anyone because of any of the protected classifications in our state of New Jersey, including religious, sexual orientation, gender identity, and expression. So here are the classifications that we have in New Jersey. Many times, and I've had this experience myself, that when we talk about discriminations, people often think of the equal, sorry, I just had my 1964, when the president signed an executive order, okay, and the Civil Rights Act, which talked about race, color, creed, okay, But that was only the beginning of recognizing the disparities that exist. Since then, and in New Jersey, we are a state that recognizes a variety of characteristics that are protected against discrimination. I mentioned before about gay and lesbian. Now here in New Jersey, we also include, okay, affectional or sexual orientation, gender identity or expression, okay, in addition to the other things that you see here, okay? So we are one of the states that is a little bit more expansive in our laws against discrimination. And even just for clarification, because I talked about what it might be like for a transgender individual coming in to be vaccinated, we want them to feel welcome, but we also want them to feel safe, okay? So the laws against discrimination state that gender identity or expression means have, or being perceived as having a gender-related identity or expression, whether or not stereotypically associated with a person's assigned sex at birth. So whatever gender a person is assigned at birth is irregardless of about how people interact, treat them, and what services they are offered or cannot be denied. And it doesn't matter whether they actually are trans-identified, whether it's true part of their trans identity, or whether they're just being perceived as being gender variant or gender difference. It's all a protected classification. So in addition, okay, just to give further clarification, I'm just going to read, it's one of the slides I think we should have to read in entire. The laws against discrimination prohibit discrimination and harassment based on actual or perceived race, religion, national origin, gender, sexual orientation, gender identity or expression, disability, or other protected characteristics. The laws apply in employment, housing, and places of public accommodation, generally places open to the public, including businesses, restaurants, schools, summer camps, medical providers, etc. Under the law, an employer, housing provider, or place of accommodation must not discriminate and must take action to stop such harassment if it is known or should have known. So yes, if we hear of, if we see of any form of harassment or intimidation occurring in any place of public accommodation, that person is violating the laws against discrimination as established in our state of New Jersey. So we have to take corrective action. That is why this presentation is being offered today, because we want to make sure individuals are fully informed and fully aware that all healthcare providers and professionals are a little bit more familiar, particularly during these very challenging times, with the civil rights of all residents and inhabitants in our state. Going back, okay, there's other media campaigns that have been used and adopted by our state. And again, this gives information about New Jersey Division on Civil Rights, how to contact them. You can go online and fill out a complaint, or you can call their helpline number, okay? And these were specifically set up for discrimination because of the basis of race, national origin, religion, still in connection with COVID-19, as far as the pandemic. Here's another one that reminds us about medical facilities. And why the first two did not include gender identity or expression, including being perceived as being transgender, non-binary, gender non-conforming, that it's also supported by the New Jersey Division of Civil Rights. So that's very important information. Hopefully, and there are other posters that are available, but they would be great if we had a variety of them up in our health departments and not just one or two, and definitely include the ones that include sexual minorities, because that's the one that is often left out when we're having conversation, which is why I personally, and that's part of what I do at Rutgers, that we make sure we expand on that. So I think we are out of time now. I appreciate everyone. I see a few chats came in, a few questions came in. Colleen, is there anything you want to run past me?
Yes, I do, Phil. I'll do it quickly. We have 2 minutes left. Thank you. That was wonderful. I will share that this presentation is recorded, and we will share this recording. There's a few comments about wanting to share it with other staff. So yes, that will be available to all of you. In our Q&A, Phil, we have a question that says this. About 20 years ago, social work schools took interest in, and this is in quotes, Asians as a privileged race. Is this now recognized as a construct that is inherently very racist against Asians?
Very good question. I don't know. I'm going to have limited how I can answer it. I believe that, like many subpopulation groups, okay, there tend to be waves. Definitely when we talked about COVID-19, as I mentioned before, the Asian community was targeted, and that targeted was orchestrated by the language that certain politicians used. It wasn't just the president, there were others that also, and that filtered into our community. How it's being taught in the School of Social Works currently, I'm really not sure.
And Phil, I'll clarify this point of the question. This is referring to about 20 years ago,
Right.
that they referred to the Asian community as a privileged race at that time.
Yeah, I never
I
heard
need
of that
more
being a-
information on this question, I'm
right,
afraid.
yeah,
Okay.
yeah. I
Okay.
do want to get to the second question that I'm seeing here from Carla, because that one I just read and I have an answer.
Sure, I know that's okay. I can share that for you. It's the question is, what happens if essentially the trusted source for community members, which in this case is physicians or pediatricians, who is the trusted source for vaccines, what can they do if local physicians are not offering the COVID vaccine?
Okay.
So
That would be, to my knowledge, and I'm not speaking as a lawyer, but as someone who is an educator on cultural competency and civil rights, okay, not as a lawyer, that could put that person in jeopardy. If they are saying they have a religious exemption to administering the vaccine, no different than, and this went to courts many years, about 15 years ago to my knowledge, a group of student nurses in our university did not want to have a rotation in OBGYN clinic because the particular clinic unit that they were assigned to as part of their nursing rotation, student nursing rotation, also terminated pregnancies, and they had religious objection to abortion. When it went to court, it was determined that they individually can object to an abortion. They, as a nurse or as a future nurse, could not refuse to give services to someone who requested an abortion, nor could they deny information, that they have an obligation ethically as a nurse to provide information. As far as the actual procedure, they can decline assisting with the procedure. They could not decline to give aftercare to an individual who has received an abortion. So the reason why I'm kind of using, and it may not be as clear when we talk about the vaccine, but the point is that the state of New Jersey said sometimes the individual religious objection is going to be overruled by the moral and professional obligation that someone has as far as what they are doing. So I don't know about, I can't speak up because I'm not a lawyer, about a physician who would refuse to offer the vaccine. I believe that if there's not, and many times when we talk about civil rights, the employer needs to offer reasonable accommodations, okay? So a reasonable accommodation would be that there needs to be a provider who will offer the vaccine to everyone who comes in. If that person is the only person on duty at one particular time and they refuse to vaccinate, that could most likely put them in jeopardy. If the facility makes reasonable accommodations and have more than other staff that will offer the vaccine, but then we are also looking at the kind of the counterpart to that is, yes, employers, including hospitals, can mandate that individuals need to be vaccinated, and if they apply for a religious exemption, it may not be granted. It is handled on a case-by-case basis. So that's how I would answer that particular question. Colleen, I think we're about out of time.
we are, Phil.
We are.
I will thank you, Phil, very much. That was great. The evaluation will appear once we end the meeting. Folks have asked that as well. And we'll share that evaluation again tomorrow directly via email. Phil, thank you so much. There are many comments thanking you for the slides and for the resources.
Thank you, I appreciate that.
Yeah.
You know, when this was presented to me, it was kind of a challenge because of, although I speak on cultural competency and racism and health risk, you know, putting it all into the COVID lens was really kind of more of a challenge right now, but I know that it's important. So I'm very glad that we were asked, that Rutgers was asked, and I was asked to contribute to this presentation, and exceptionally happy that we have 126 people now continued. I don't know how many we started with, but we still have 126 here now, you know, 2 hours later or hour and a half later. So thank you all very much. And please, Colleen will share information with you. We'll be giving you the handouts. We'll be giving you a PDF file also will be available, and contact information is also available. And my contact information on the screen right now, email, although my phone is active, I'm not in the office, but I will respond to email if I have an individual that can assist you in any way. Thank you, Colleen. And
Thank you. Thank you so much, Phil. Thank you everyone for joining us, and have a great afternoon. Take care. Bye-bye.